Good evening, everyone. How are you? I am doing awesome. I'm having a great day. All day I was excited to come here and talk with you all in the I Care for Your Brain program with me, Dr. Sullivan, about a really important aspect of life, something that's very under-recognized, under-treated, under-diagnosed, but that can have really big implications for quality of life and recovery after a medical crisis. And what I'm talking about is post-traumatic stress disorder. There is a formal, hi Allison, there is a formal, I got distracted for a second, diagnosis, of course, of PTSD, post-traumatic stress disorder, but really there's a whole spectrum of traumatic stress symptoms that we're going to cover tonight and talk about how maybe you are fitting somewhere in this spectrum, why it's important to recognize these things, how it can be interfering with your recovery from a medical illness, and what exactly is it that I recommend that you do about it. So post-traumatic stress disorder is something that has been talked about actually for kind of a long time now. It has gone by many different names. You might remember sometimes they would call it shell shock in about World War II, and it's gone through several different names, but commonly we have associated it with people who have gone to war and have been in combat, people who have been physically assaulted, people who have been sexually assaulted. But about 15-20 years ago, they started to expand the types of trauma that could lead to PTSD to include things that happen within someone's physical body. And this is where we started to think about things like a cancer diagnosis, a stroke, being told about a neurological illness, a cardiac arrest, even a traumatic fall can actually result in symptoms of post-traumatic stress disorder. So what we know is that the definition of a traumatic event, which you have to have in order to have a traumatic stress syndrome, is something that is either life-threatening or something that is disturbing to you to such a degree that you have feelings of horror or helplessness when it either happens to you or you witness it happening in someone else's life. Typically, these traumas are sudden and unexpected and not something that we felt prepared for. And in fact, that's part of the psychological shock, is that we really didn't see it coming. The feelings that happen in response to the stressor are ones that include really intense feelings of fear and helplessness. And for a lot of people, there's kind of an out-of-body experience that happens, either at a time where they are being told something very traumatic, where something very traumatic is happening to them, like a stroke, or like I said, when they see something or hear about something very traumatic that happened to someone else. If we don't acknowledge that these symptoms are an aspect of a medical crisis, we are really missing an opportunity to truly help people get better. And I'm going to share some data with you tonight that shows if you have these symptoms and you're not being treated, you really will not get as well as you could if they were simply acknowledged and treated. But what we also know is that this is really a way to provide true empathy and compassion to other people who have been through a medical crisis. Because if we just treat it like a medical problem, if we reduce all of our questions and concerns to things like medications and the hospital stay, it's really taking away a very salient human aspect of the crisis, which is, how did it feel? How did you make sense of it? How did you find meaning in it? How are you going on in life, being reminded sometimes about this traumatic event that happened? And that's really where PTSD gets people. It's the little reminders that come up. And we're going to get all into that when we talk about the symptoms. But I did want to use stroke as just kind of an example tonight to flesh out this idea. And because so many of you listening are thriving and living with stroke and in your stroke recovery, I thought it would be maybe helpful to have some specific data that talked about this. So the rates of post-traumatic stress disorder after stroke have been estimated to be anywhere from about 4 to 37%. And that was We didn't have a good number because all the studies were pretty different and they were actually pretty small. So in 2013, a study out of Columbia University actually gave us the very best data because it had the largest number of people who had had strokes. And what they estimated is that about 1 in 4 people within the first 6 months after a stroke meet criteria for PTSD. And about a year later, this drops down to about 1 in 9. So this puts us at about, 24-25% of people who in the recent past had a stroke are living with post-traumatic stress disorder. And I don't know about you, but I don't think that we're talking about this nearly enough. I don't think that we are assessing for it nearly enough, and we're certainly not treating people enough for it. So this is why we have to bring it back to the conversation. So what we know is that these numbers actually pertain if you have had a full-blown stroke, or if you've even had something like a TIA, which is called a transient ischemic attack, which are stroke symptoms that actually completely go away within a few minutes to an hour and don't leave any long-term effects, but still the person has lived through the traumatic experience of having had those symptoms. I want to talk a little bit about who is more likely to get PTSD after a stroke, but I think we have to cover 2 things first. The first one is, what makes this important? What are the reasons why it's worthy of our time tonight, and why, as a neuropsychologist, I really prioritize this in my folks who've had a medical crisis? The first one is that when these symptoms don't go away over time, they tend to get worse, and there's a very good reason for that, which we'll discuss. But the main thing for me is that we have evidence that there is less physical recovery. There is a less return of independence for people post-stroke. It's actually associated with people not being good about taking their medications post-stroke, and this has big implications for managing some of the cardiovascular issues that maybe got the stroke happening in the first place, or maybe also some of the post-stroke mood symptoms that I have been talking about, like depression and anxiety, which we're talking about tonight. We also know that it really reduces quality of life, not only in you, but in the people that are very close to you, that love you, the caregivers, the people that are really right by your side throughout the stroke. We know that stress hormones, which are rampant in things like post-traumatic stress disorder, really hurt the brain. Do you remember our talk last week? We talked all about how these stress hormones like cortisol are actually toxic at the cellular level to brain cells. And this really happens in the memory parts of the brain and the prefrontal cortex. And nobody needs that, never mind if you've already had a brain injury from a stroke. Anxiety, of course, also interferes with us thinking clearly, being able to put a good plan of rehab into place, and for our motivation to get up every day and to do the hard work of recovery. Anxiety in all its forms, which PTSD is an anxiety disorder, is very, very taxing physically. We talked about this last week. You hold it in your body, and part of that is because you try so hard to keep it off your mind due to a symptom called avoidance, which is kind of the root at PTSD. What we typically do is stuff it down into the body, or we run ourselves so ragged during the day that we are exhausting ourselves, burning the candle at both ends. Of course, PTSD really has a big impact on sleep, and that is because the body, the nervous system, is just running really, really, really high. During the day, if you can be productive and get out and do things and talk to people and fill your time, it cannot hit you quite as much, but when your head hits the pillow at night, it's like it all comes right back to you. So what I want to do now is explain to you what the formal criteria is to be diagnosed with PTSD. And I want you to be listening to think, okay, that either sounds like me, sounds like someone I love, or remember, a very important point tonight is it's kind of arbitrary how we slice and dice psychological diagnoses. You either have 4 out of 6 symptoms, it's a check, or it's a minus. I would much rather you think about psychology and our mental health on a spectrum. that there is a lot of gray, and you may have a little bit of these symptoms. You may have a ton of these symptoms. It's really all about the intensity of symptoms and how much they interfere with your quality of life, your relationships, and your ability to do what you want to do every day. So the first thing with PTSD is you have to have a traumatic event that kind of meets what we call a criterion A event. These are those life-threatening events. I would absolutely put stroke on this spectrum for sure. After you've gone through that event, and over the course of a month, so we kind of give people a month to have something called an acute stress syndrome, which is basically what almost every person would have who underwent, a plane crash, a stroke, a car accident. But after about a month, some people actually process the experience. They have a lot of other positive supports in their life, and they don't develop PTSD. Remember, I said only 1 in 4. So that means, 3 out of the 4 people in the stroke category are going on to not develop PTSD. So after about a month, we have 4 symptom clusters that I want to describe to you. So the first one we have is intrusive symptoms. And what this means is whenever you get a reminder of something that happened to you, now this can be a smell. The smell of the hospital is huge for so many people. If you haven't been in the hospital, think of like the dentist smell. When you go in there, it's just like, it's almost visceral how it makes you feel. It can be an internal, like a nightmare. Basically anything that makes you feel like you're almost reliving the event, something that makes you feel like you're right back into that very circumstance, and it can have a lot of physical feelings of anxiety. Your heart can start to beat fast, you can kind of get kind of clammy, but really what it is that there's a reminder, kind of a trigger, and it kind of opens the floodgates. Now, part of why there's so much power behind that trigger is because of avoidance. And this is such a huge concept that if you can get this, I promise you, you will reduce stress in your life. We talked about this last week, and it's really the beginning to understanding what PTSD is doing to you. So what avoidance is basically, I would really like to put this into a little box and never think about it again. I want to pretend like I never had a stroke. I don't necessarily want to talk about it. Feeling very emotionally numb, because you don't get to pick and choose with emotional avoidance. You don't get to say, I don't want to ever think about the bad stuff. What happens is it all comes together. It's all a big mishmash. And if you try to get rid of the negative, what happens is you actually numb out everything. And people can talk about, I kind of feel like I'm on an island emotionally. I think I love my family, but the truth is I don't feel that connection to them anymore. And it can be very disturbing to people, but the truth is you're kind of cut off. You're kind of overwhelmed to the point where I cannot feel anymore. I don't feel like I can take anymore. The other thing that can happen is a set of symptoms called hypervigilance. And what this is, these are all interconnected. It's so fascinating. Is all the stuff you're avoiding here is getting pushed down so much that you are basically on kind of an unconscious state of hyper alert all the time. Now, for someone who was maybe in a tornado, when the clouds start to get a little bit dark and it gets that certain kind of atmosphere, people can start to get triggered, and they might have their re-experiencing symptoms like the rapid heartbeat, getting really clammy, getting really nervous. Well, for someone with a stroke, what happens when you have a normal physical symptom that maybe was one of your first warning signs that you were having a stroke? What if all of a sudden, you start to get a little tingling in your left hand, or all of a sudden you get a headache, and oh my God, is this going to be another stroke? I think if you're listening and you relate to what I'm saying, I would love for you to chime in, because I need you guys to tell me that I'm getting this right. But I have talked to enough people and care about enough people who've had strokes to know that that's a really big one. And the final one is negative alterations in what we call our cognition. So basically this is that the traumatic event has really made you feel differently about either yourself, other people, or your safety in the world. So the truth of the matter is that when you have not had a traumatic event happen to you, you and me and many other people are really living in a little bit of an illusion that life is very safe and that we're all going to live to be 90 and 95 and die a very peaceful death. And that's a schema, that's a belief that we're carrying around. When something like a stroke, especially at a young age, happens to you, that was not what you predicted your life was going to be. And so there can just be a lot of global negative statements that people make as they're working towards their recovery. So something like, I'll never be me again. You know, life sucks. This is never going to be okay. I'm ruined. No one's going to want to, I'll never date again. Just these very global blanket statements. So when this goes on for over a month, and when we know it's not related to anything else, and it really interferes in people's life, we start to think about post-traumatic stress. Now, I want to give you some kind of rules about when you should be concerned, because it's a fine line to know, okay, should I talk to someone about this? What am I supposed to do? So the first one is when the emotions are really, really, really high to where the person cannot manage them without some kind of professional support. So triggered to the point where they're crying a lot, they're isolating a lot, they don't want to talk to people, they're kind of jumpy, they're just like really, really, really kind of high strung. The next one is if things get worse and worse and worse and worse, meaning their symptoms get more and more and more intense. And I was telling you before, this is what will happen in PTSD without treatment, because that avoidance does not just stay at a certain level. What happens is the world, and if you know someone who has PTSD, this is what happens. The world for that person gets smaller and smaller and smaller, and the list of things that feel safe gets larger and larger. So, you know, a lot of times people with PTSD don't like crowds, and part of it is that you're on such high alert about what everyone's doing, you're really overwhelmed. So you first might hear someone say, well, I don't want to go to the mall anymore. Then the next thing, a couple months later, I don't really do movies anymore. Well, then it becomes, I'm not really going to do family gatherings anymore. It's too much. Then it becomes, I'm going to set up a man cave downstairs and you can bring me my dinner down there. So the world shrinks, and that is very bad for people psychologically, very bad for people socially, terrible for recovery, and horrible for brain health. So we gotta focus on this. The next one, of course, is if someone's anxiety interferes with them doing their rehab. So I can't go to the physical therapy office because I have anxiety attacks. I don't want to do my exercises at home because I think, why bother? I'm not going to get well anyway. When someone is cutting off their own nose despite their face, and you have a good idea that for yourself or someone else that it's due to anxiety, I really think of this like an emotional emergency. We really have to take this serious because there are long-term outcomes at stake. So what are some predictive factors? Remember I said 1 in 4 gets the PTSD, 3 in 4 don't. So what are the unique issues that are making those 1 in 4 go on? So I want you to understand that in the general population, the more traumatized you are throughout different events in your life, the more likely you are going to be to actually develop PTSD. So we see this a lot in military veterans, people that went into the military because maybe they had a really tough early life in foster care, physically abused, had no social support whatsoever, maybe had a couple assaults, go into the military and they have to go to combat. They are much more likely to develop PTSD because they've already been through something really hard. And remember, what I was trying to teach you before is one of the biggest ways it gets us is this changes our worldview. So if your worldview is already that people are terrible, bad things are going to happen to me, and that gets confirmed by yet another traumatic event, it's like you didn't have that far to fall before you really start to feel those symptoms. So that's just across the board. Interpersonal trauma is much more damaging to us psychologically than physical trauma or trauma caused by natural events. And that's really due to our social nature, right? And that we really carry around with us these ideas, you know, if I'm a good person, good things should happen to me. Do good in the world and you'll be rewarded. You know, do unto others as you would have them do unto you. And unfortunately, when people have been traumatized, the vast majority of times it's very unfair and it's very unprovoked, and there's nothing at all that the person could have done. But we get very, very damaged when social norms, expectations that we have for parents, and really how it relates to stroke is, our own body. It can feel like our body betrayed us. So whenever things happen kind of in a person-to-person level, just in general, that is a risk factor. But in terms of stroke, there's a little research that suggests that the younger you are, the more at risk you are. And again, I think that's that out of the blue, this was not what I expected. There is some suggestion that women are more likely to get it, but I think the researchers did a really good job in kind of reasoning that women are actually much more likely to have previous traumas just through the way our cultures are. And it's kind of that cumulative effect, so that might have something to do with it. There are some suggestions that personality factors can play out here. So people, remember when I talked about post-stroke depression, and I told you if you had depression before your stroke, you were way more likely to wind up with post-stroke depression? Well, it's kind of the same thing. So basically, if you were kind of an avoider before and you really didn't do good with stress and emotional difficulties and you just wanted to push it out of your mind, those people are more likely to get PTSD after a stroke. If you were someone who wasn't very good about naming your emotions before a stroke, this can be part of something that raises your risk. And if your coping in general was not that great before, probably not going to be that great after. There are some suggestions that hemorrhagic stroke survivors do a little bit worse in terms of PTSD, specifically fear about another bleed. And this gets back into that hypervigilance symptom cluster, which is how do you learn to live in a body that is going to have quirks and aches and pains and headaches and numbness that are all just part of normal living, without feeling like this is a stroke warning sign and I need to get to the emergency room. I think that has to be really, really, really hard to know. When do I protect myself and go to the emergency room versus I've been there 3 times this week and they keep telling me I'm fine? That's got to be really hard ground to figure out. There are no studies at all that I could find that talk about the location of the stroke and being more likely to get PTSD. There's a lot of overlap in general, not just in people with a medical crisis, between depression and PTSD, and part of that is because PTSD is actually very depressing. It's very isolating. Remember I was saying the worlds get smaller. Well, when that happens, you typically don't find much joy in other people or doing things because you're not really exposed to those things. Remember what I was saying before, traumatic stress happens on a spectrum. So you may not meet the full criteria, but that doesn't mean that I don't want you to think about this and I don't want you to get the help that you really need. So let's talk about what to do about it. So let's stick with our stroke folks for a minute. I looked at the literature again last night, and there's really no reports out there that say when you have post-stroke PTSD, here's what you should do. But we do know what works for PTSD across the board, and it's been shown, the therapy I'm going to talk to you about has been shown to be really, really effective in people who have lived through rape and military combat. So once upon a time, actually about 5 years ago, I was going to submit a grant to look at this very thing, and I wound up leaving the place that I was working, but I think it's a awesome, important thing for people to study. So I want to tell you a little bit about a certain type of cognitive behavioral therapy called cognitive processing therapy, and this was developed by Dr. Patricia Resick at the Boston VA through the National Center for PTSD. She's actually up the road at Duke University now, and I had, as I did my training at the Boston VA, the pleasure of going through this training, and it is a manualized therapy, and really the heart of it is getting people to understand how the trauma has affected the way that they think about themselves, other people, or the world, and to recognize that the changes in their thinking very often are what we call distorted, that they're not really balanced thoughts, that they're very extreme, and the truth is that they're a form of coping. And the way that we all typically cope with stress is we actually put it on us. There's a lot of shame and guilt and blame that happens after a trauma. And this is, sexual assault all the way up to stroke. What did I do? What didn't I do? If only I did this. Why did I lift those weights at the gym and, have my dissection? Why didn't I stop smoking? Why did I walk down that alley to get the cab? And isn't that amazing? Because we really have no control over it. But psychologically, there's something very, very scary about admitting that there really is no control over these things. And the truth is that trauma tends to be very random. And like I said earlier, very unfair. And part of her excellent therapy is to really help people understand how to find meaning and make peace out of what has happened. Really, how are you going to go on and live a life of quality? So the 4 main goals of cognitive processing therapy are educating the person about PTSD. And this is very meaningful to me because, as you guys know, if you watch the show, that this is kind of my whole thing. The whole basis of why I'm here is that I truly believe that once you know better, you do better. And so many people out there are internalizing that something is wrong with them or they are not doing something right when it's actually a brain-based problem. And PTSD is very, very much brain-based. So we like to educate people about what PTSD is, how treatment's going to help, which is kind of like the buy-in to make them come to all the sessions, really helping them stop avoiding, starting to get very internal about their thoughts and their feelings. So there's a lot of journaling and reflecting and coming into the sessions with some homework. But we're trying to really teach people coping skills, which is what has happened, what is the price that you have paid, and is it more than your fair share, so to speak? What is it that you can do to keep this trauma in its appropriate, healthy place in your life? That may be something that you want to pursue, and there are actually a lot of psychologists who come through the VA system who have been trained in cognitive processing therapy, and you can go online and try to find someone. But I also wanted to talk, as we end the lecture today, about the very, very, very important concept of self-care, which is maybe you didn't see yourself in all my symptoms tonight, but you feel like, you know what, I have been through a lot, and that heart attack that I had, I am very jumpy ever since it happened, and I have nightmares, and I'm so afraid it's going to happen again. What are some of the things that you can do yourself? So first thing is I want you to remember that your emotional recovery is just as important as, say, a physical recovery. So, after a cardiac arrest, it takes someone a while to have physical energy and be able to get back into being active. Well, emotional recovery, we can't see it. We can't really observe it as an outsider, but the truth is it's slow too, and you're not going to feel immediately like yourself. This is a very intense event that has happened to you, and it's simply going to take time. So you really have to be patient and think about that whole concept of self-compassion, which is how would you treat a best friend who had the same thing happen to you? For some reason, we're so much better at taking care of other people than we are at taking care of ourselves. I want you to hear what I said about avoidance. Avoidance is the enemy. You think by thinking about it, you're going to feel worse, but the truth is not thinking about it is making you worse. You think you're being all clever and you push it out of your mind during the day, but I know I'm right when I say it comes back to you at night or it comes out in your body. So with the help of someone that you love and trust, whether it's a professional or close person in your life, I really would like you to try to work up the courage to talk directly about what's happened to you and how it made you feel at the time, how it makes you feel now. I want you to remember, like we talked about last week, we hold on to trauma in our body. It's a very physical experience. And really, it's held in our nervous system. And if we're meant to be running at a 5, if you have PTSD, you're kind of at an 8 or a 9 all the time. And part of how you're going to work yourself down is by really respecting the need for the body to rest and to rejuvenate. So I want you to think about things like prioritizing sleep, trying to move your body as much as you can, being around people that are truly supportive and that ask you questions about what's going on with you and don't just give you the impression that you're supposed to get over it and not ever talk about it again. Keeping stress low is extremely important. Remember, stress is very toxic to our brain health, so we got to try to keep the drama level down, and be with, the good people, the ones that make you laugh and make you feel happy. If you don't have people that are very supportive right now in your life, you have to try to find new people, or really start to develop resources within yourself that you know that you're getting stronger and stronger every day, that you can rely on yourself in the future. So much of this is about safety and security. If someone that you care about sounds like what I talked about tonight, there's 3 things that I want to encourage you to do. So the first one is don't collude with avoidance. Don't go along with their sneaky ways of trying not to talk about it. This really goes back to even the time when someone's in the hospital. And the idea is, let's not allow this to just become medical. We have to respect the fact that this is a person, a spirit who is going through this. And I want you to feel comfortable saying, how are you feeling with all of this? Are you scared? Are you anxious? Do you feel like crying? And allowing people to just simply express themselves. You don't have to do anything. You don't have to change anything. You don't have to solve the problem. You are just going to let it be. But encouraging conversation is extremely, extremely powerful. When unpredictable things happen, the biggest effect that it has on us is this fear, where we feel that the world is out of control and that things are very unpredictable. So what I'd really love you to do is to really emphasize themes of security and stability to the person. So we want to be very reassuring, and how we can do that is by saying things like, you're okay now, you're with good doctors who are going to take care of you, I'm going to be here for you. Keeping a good regular schedule of events where there's predictable things that happen at the same time every day. It sounds very basic, but it can actually go a long way to just resetting someone's brain, because remember, the trauma is that something so unexpected happened that it's almost like life got turned around. So the more we can get back to the normal routine, the better. Using reassuring touch, respectful touch, asking people if it's okay to just put your hands on them, I think is a very powerful way to communicate safety and security to someone. I hope that this was helpful. I hope that you all agree with me that this is a very important thing that we talk about. I feel so lucky every day that I picked neuropsychology as my focus of my life, because I really believe that it has the tools to help people. And I think a big part of how psychology helps is the openness and the talking and the validating, that these things are really just as important as a blood test or an MRI. And we have to really work towards changing the focus of medicine to not forget the person. We really have to work towards patient-centered brain health. Okay, so if this was helpful for you, I would love for you to share it on all of your boards, on your page, because I want people to get this information. We're going to continue next week with Mental Health March by talking about cognitive symptoms of depression and anxiety, which is really important because it's really not just a feeling issue. Oh, I feel kind of sad, or I'm worried. The truth is there's cognitive symptoms, memory symptoms, attention symptoms. So I want you to understand that so you know what to do. Next Wednesday, though, at 6, I'm actually going to be doing a talk up in Durham. And what I'm going to do is tape that talk the night before. So it won't be live, but it will be on at Wednesday at 6. Please leave me a little note here and let me know if you like this. I love to know that these talks have had a positive impact on you and that it just got you thinking in a new way, or even inspired to do something about something that's been bothering you. So thank you guys a million for watching, and I hope you have a great rest of your night. Thank you so much. Bye-bye.